Hello everyone, I'm Tomoshige Matsumoto, Osaka Anti-Tuberculosis Association, Osaka Fukujuji Hospital, Rheumatology and Internal Medicine. Thank you for attending my session. In the last few years, COVID-19 has had a significant impact on the treatment of infectious diseases, including tuberculosis. So today, I would like to talk about the precaution to be taken regarding reactivation of infectious diseases when using cytokine modulators, which are now used in rheumatology and dermatology area as the first topic, and as a second, the status of tuberculosis and COVID-19. In the first half, I will discuss the development of biologics that modulate cytokine signaling, the concept of exacerbation of latent infection caused by administration of these drugs, and the precautions to be taken when using these drugs approved in rheumatology and dermatology fields. In the second half, I will discuss the status of TB and COVID-19, COVID-19 therapy, and TB reactivation and COVID-19 therapy. I will start talking cytokine modulating drug and opportunistic infection. This slide shows the history of RA drugs in Japan. Sorry for a busy slide. This lower part describes the approval year of each drug. As you can see at the upper part, the associated guideline and guidance for the drugs are in place shortly after drug approval. In 19th, the molecular biology came flourish. The IL-4, 5, and 6, etc., these cytokines were cloned. The three drugs in red are the most memorable to me. In 1993, the anti-IL-6 receptor antibody was administered to the patient for the first time at Osaka University Hospital. At the time, I graduated the medical school as a research resident and found SSI1 an endogenous JAK inhibitor, currently called SOX, with Professor Naka of Osaka University, 1997. Next year, infliximab was administered to a RA patient for the first time in Japan by Professor Saiki group at Osaka University. I closely watched it. This slide shows the importance of endogenous JAK inhibitor for the survival. The JAK STAT pathway plays an important role in signal transduction. IL-6 signal also uses this pathway. 4 JAKs and 6 STATs had been known at the time, and we were hunting the 7th STATs at the time, but couldn't, and finally found a JAK inhibitor which was induced by STATs and named SSI1, currently called SOX1. This molecule carries a negative feedback function of cytokine signal reduction. SOX1 deficient mouse is born normally but dies within a month due to growth retardation. This indicates endogenous JAK inhibitor is inevitable for life maintenance. The body has both positive and negative feedback mechanism. The equilibrium cannot be maintained without negative feedback mechanism. Just as a car has three brake systems, engine brake, side brake, and foot brake in the relation to an accelerator, the intracellular jack-stat signal pathway has three known brake systems, SOX, PS, and phosphotyrosine phosphatase. Marimon et al. Shows the JAK inhibitor towacinib mimics the function of endogenous JAK inhibitor SOX and SOX3. In 2000, in order to apply the treatment of suppressing cytokine signal to humans, I administered anti-IL-6 receptor antibody, Actemra, to patients with Castleman disease and rheumatoid arthritis, which I will discuss later. In 2008, Actemra was approved in Japan. Infliximab Remicade was approved in 2003. This is the first RA patient case we could safely re-administer infliximab in 2004 and published in New England Journal of Medicine in 2006. For RA patients who developed active TB during the infliximab therapy, we completed TB therapy and could restart infliximab therapy without any adverse events. In 2018, we have conducted GBAS genome-wide analysis study analysis of multi-drug resistant Mycobacterium tuberculosis using our knowledge of gene cloning and kill mice and to analyze the relationship between drug resistance genetic mutation. Then, based on the past works, I participate in compiling the second edition of the guide to biologics for inflammatory disease and respiratory disease practice in 2020. Recently, Nigrovic and others had proposed the concept of inflammatory disease. This concept divides immune function into three axes: pathogen susceptibility, antigen-dependent inflammation, and antigen-independent inflammation. They explained pathogen susceptibility as immunodeficiency, antigen-dependent inflammation as autoimmune diseases or allergic disease, and antigen-independent inflammation as autoimmune and antigen-independent inflammation as autoinflammatory diseases. They were discussing the main cause of inflammatory disease and their overlap. Diseases are classified along their interferon axis, NF-kappa B TNF axis, and other axes with dermatomyositis, SLE, etc. On the interferon axis are stale disease, gout, etc. on IL-1 axis. Based on this concept, it is expected that more and more cytokine modulating therapy, such as biologics and JAK inhibitor, will be used. In summary, so far this is a well-known mechanism of exacerbation of past infection. The use of immunosuppressive drugs, biologics, aging, diabetes, dialysis, etc., in patients with inflammatory disease or healthy individual can lead to decline in host immune system, resulting in adverse events such as reactivation and exacerbation of infection. Infections are common and critical adverse events of all biologics in terms of frequency and severity. This is a table in the latest TB infection treatment guideline of Japanese Society of Tuberculosis. It shows relative risk of active TB development and its recommendation for TB therapy necessary. These numbers indicate the active TB development risk against a healthy LTBA carrier as 1. For example, if a patient has HIV, then the TB development risk skyrockets. The treatment recommendation categorized A to C according to the TB development risk. A in red means treatment is necessary. B in blue means treatment is necessary when more than 2 conditions coexist. As you can see, the biologics use is defined the risk 4 times higher and TB treatment is recommended. So now I would like to discuss in particular about TNF-alpha in our area. The goal of treatment of rheumatoid arthritis is not only improve clinical symptoms, but also to improve long-term prognosis, especially prevention of physical dysfunction and improvement of life expectancy through inhibition of the joint disruption. This is a significant step forward in the treatment of rheumatoid arthritis. This is established because of dramatic progress in the treatment of rheumatoid arthritis as a fact that the current therapy measures are able to improve clinical symptoms and prevent the prognosis of joint disruption. The Rheumatoid Arthritis Treatment Guideline 2020, the algorithm for treatment was updated in detail. According to the new guideline, the algorithm for drug therapy is divided into 3 phases of treatment. In phase 1, rheumatoid arthritis is diagnosed and treatment is initiated with C-DMARS, mainly MTX. If goals are not met, biological DMARS or TS-DMARS as phase 2. If goals are still not achieved, the patient is moved phase 3 as biological DMARS or TS-DMARS are switched. Corticosteroid, NSAID, and anti-RANKL antibody will then be used as adjunctive therapy if necessary. Let's talk about TNF inhibitor in rheumatoid arthritis field. Currently, anti-TNF inhibitors were approved for the treatment of RA in Japan. infliximab, etanercept, adalimumab, and golimumab, and certolizumab pego, and now ozoralizumab. As in the guideline of American College of Rheumatology and the European College of Rheumatology, earlier diagnosis of RA and initiation of MTX and introduction of biological agent if necessary, they are recommended. TNF-alpha inhibitor are listed in the guideline, but one should be aware of recurrent infection during this use. In 2001, King et al. Reported that TB, especially miliary TB, was more likely to occur in patients treated with TNF inhibitors. The TB was usually encountered in clinical practice is mainly pulmonary TB, but the TB developed with anti-TNF inhibitors is often miliary TB, which became a problem because many deaths occurred due to delayed diagnosis. This is a well-known mechanism of TB reactivation after TNF-alpha inhibitor administration. In the latent tuberculosis state, dormant mycobacterium tuberculosis surrounded by macrophages and lymphocytes, and the action of TNF-alpha, T cell, and interferon gamma, and is contained as a fibrotic granuloma. When TNF-alpha antibody is administered to rheumatoid arthritis with latent TB for rheumatoid therapy, the granulomas break down and reactivation of tuberculosis proliferates and invades the airway and blood vessel through the tissues. Since the discovery of this phenomenon, it is being required that before administering TNF-alpha to be a patient with rheumatoid arthritis, one should carefully check the patient's TB infection status, that is, whether the patient has active TB or not, or whether the patient has latent tuberculosis infection. In the past, it was not specific whether TNF-alpha could be administered to RA patients with active TB after completion of TB treatment. Thanks to the development of biologic agents, administration of these drugs has been recommended in the early stage of disease onset to control bone destruction and maintain ADL in the past. However, in the patient with TB, there was no evidence if the patient can be administered to the patient after TB therapy completion. In 2004, we administered that infliximab could be safely and effectively administered to patients who had developed tuberculosis after receiving anti-TNF agent infliximab. And our results were published in the New England Journal of Medicine in 2006. Based on our and other results, as shown with red arrow, re-administration of biologics after completion of TB therapy was enabled. Now, it is important to check for the TB infection before administering the drugs. But what If active TB developed during TNF-alpha administration, currently the three approaches listed here were introduced in the guideline of various countries. The first is to restart biologics after completion of TB treatment. Second, restart biologics 2 months later in parallel with TB treatment. Third, if the TB is not resistant and it is known that TB treatment can be done safely and reliably, continue biologics without interruption. This is unique only to the Japanese guideline and so to say the latest protocol. This table compares the frequency of various infections after initiation of treatment in post-market surveillance of anti-TNF inhibitors and other biologics agents currently used in the treatment of RA in Japan. In case of TB reactivation, the first TNF-alpha inhibitor approved stands out. This is presumably due to the fact that the mechanism activation, as mentioned earlier, is now known, leading physicians to pay attention to the risk of TB relapse, and that the even so-called biologic agents each has different mechanisms of occurrence, depending on the cytokine signal it blocks. Next, I will briefly note the use of JAK inhibitors, which are indicated not only for RA, but also atopic dermatitis. JAK inhibitor includes Xeljanz, Olumiant, Rinvoq, Smyla, Giselca, and Cymbico, and are now indicated for a wide range of conditions including rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, atopic dermatitis, and COVID-19 pneumonia. This is the header and warning section of the package insert for these drugs. Sorry for Japanese. The warning section of the package insert for all drugs allows the physician to be aware of tuberculosis, to check for TB infection by chest X-ray, IGRA, or CT, if necessary, to proceed TB treatment if suspected, and to remind the risk of TB reactivation even in IGRA-negative patients. I will show you a case report. An 84-year RA patient. He was T-spot negative prior to baricitinib administration. Thanks to drug RA activity dropped, but 5 months later he developed active TB. We have to lesson from this. Now, I would like to begin to discuss biologics in the field of dermatology. The Japanese Dermatological Association has issued guidelines for the use of biologics in psoriasis in 2019. Sorry for this busy slide, you may not see the detail, but what I would like to say here is, in addition to TNF inhibitors, there are other biologics approved for the use in psoriasis, including IL-12 inhibitor and IL-23 inhibitors and IL-17 inhibitors. I have tried my best to translate the contraindication and precaution section into English in the attached document of these drugs. I'm not sure if my English is up to the task. The content of contraindication is a patient with serious infection including active TB are listed as contraindication to treatment, and that screen should include interview, tuberculosis skin test, and chest imaging, followed by IGRA, and consultation with medical specialists are necessary to make comprehensive assessment on the presence of respiratory tract infection, including pulmonary TB. Personally, I don't think that tuberculosis skin test is necessary though. In addition, Dermatological Association guidance on the use of biologics in psoriasis states that IGRA should be performed periodically after initiation of treatment with biologics if the patient has a history of tuberculosis infection or chest findings that are consistent with old tuberculosis. Three drugs, baricitinib, upadacitinib, and abrocitinib, which I mentioned earlier in the rheumatology section, are now also available for treatment of atopic dermatitis. I personally have the feeling these drugs work very well. No guideline has yet been prepared describing the precaution to be taken when prescribing these JAK inhibitors for atopic dermatitis. However, the package insert for these drugs includes warning for tuberculosis. Last year, Olumiant received an indication of alopecia areata last summer. I have talked about the development of biologics that moderate cytokine signaling, their indication in rheumatology and dermatology, and the risk of infectious disease reactivation, including tuberculosis, when these drugs are prescribed. Now, I would like to talk about TB and the COVID-19 pandemic. WHO Global Tuberculosis Report 2022 stated that coronavirus infections have a significant impact on health, society, and the economy. WHO reports significant decrease in the number of patients diagnosed with TB compared to 2019. In most countries, the number of newly diagnosed cases of TB is affected by COVID-19. Compared to 1917, TB deaths increased in 2020 and 2021. Similar phenomena has been observed even in Japan. As you can see, compared with 2019, the number of newly diagnosed TB patients and LTBI patients who need TB therapy sharply dropped in 2020 and 2021. The apparent decline may be due to patients being overlooked and refraining from receiving medical care due to the spread of COVID-19 infection. This graph represents the TB incidence rate of each prefecture in Japan, comparing between 2019 and 2021. Orange, 2019, blue, 2021. In many cities, TB incidence rate decreased between 2019 and 2021. As a result, in 2021, Japan became TB low endemic country of TB incidence rate of 9.2. This decline is assumed due to the impact of COVID-19, and we will need to monitor this change in the future. This slide shows the relation between newly diagnosed TB patient number and COVID-19 patient number in Japan. The blue bar indicates TB number. The orange line, COVID case. The red arrows indicate the pandemic waves. The new TB cases has been declining since December 2019, when COVID-19 pandemic started with a sharp drop with each COVID wave. Now we will start to talk about IGRA and QFT used for diagnosis of latent TB and TB. The intended use of IGRA QFT Plus. IGRA QFT Plus can be used not only as a diagnostic aid for latent TB infection, but also for active TB. The use of IGRA QFT Plus in the diagnosis of active TB is unique to Japan, but it is particularly useful in the diagnosis of extrapulmonary TB. FDA approved IGRA include QFT and T-spot TB, both based on the principle that the T lymphocyte sensitized to Mycobacterium tuberculosis produced type 2 interferon when exposed to Mycobacterium tuberculosis specific antigen. This is the measuring principle of QFT Plus. The QFT Plus blood collection tube consists of 4 tubes: negative control, TB1 antigen, TB2 antigen, and positive control. The green cap TB1 tube is coated with E36 and CFP10 long-chain peptide, a stimulating antigen on its inner wall. The sensitized CD4 T cell produce interferon gamma as an immune response. The yellow cap TB2 tube is coated with the same long peptide as TB1 and a short peptide of CFP10 as a stimulating antigen. The sensitized CD8 T cell produce interferon gamma as immune response to this short peptide. Therefore, amount of interferon gamma in the TB2 tube is the sum of CD8 and CD4 immune responses. The figure shows the result of the QFT plus sensitivity and specificity meta-analysis. The QFT plus sensitivity was 94%, the same as the FDA approval sensitivity, and QFT plus specificity was 96%, similar to the FDA approved specificity of 97%. The TB2 sensitivity was higher than the 95% TB1 sensitivity of 91%, suggesting contribution to sensitivity from TB2. There are 3 points to keep in mind when diagnosing latent TB. First, notification. In Japan, when a physician diagnoses latent TB, he or she must notify the public health center if he or she intends to treat the patient for TB. Second, public expenditure. In such cases, the necessary tests and treatment can be covered by public fund if the notification is made. Third, treatment. Treatment is in accordance with the treatment guideline for latent tuberculosis infection issued by the Japanese Society for Tuberculosis. I would like to discuss the positivity rate of IGRA in immunocompromised hosts. This is a head-to-head study of Professor Igari at Chiba University. He compared the IGRA positive rate of his RA patients undergoing various treatment regimens between QFT plus and T-spot TB. QFT plus showed higher positive rate. Professor Igari also reported higher positivity rate for QFT plus among his HIV patients. And he reported a higher positive rate of QFT plus in renal transplant recipient in head-to-head comparison. Summarizing these 3 reports, we could say QFT plus has a higher positivity rate than T-spot TB among the immunocompromised hosts, such as HIV patients, RA patients, and renal transplant patients. For elderly people as a kind of immunocompromised host, Dr. Fukushima at Nagasaki Isahaya Red Cross Hospital reported a head-to-head comparison result. QFT plus, QFT2, T-spot TB using his active TB patients. In the report, more than 40% of patients aged 80 years or older had impaired immune function with CD4 T cell count below 200. And QFT Plus maintained sensitivity and lower false negative rate among everyday active TB patients compared to other IGRAs. This literature suggests QFT Plus is less susceptible to immune compromise. Next, I will discuss immunosuppressive agent for COVID-19 treatment. Let's look into WHO living guideline for COVID-19. In the January 14, 2022 version, WHO announced that the combination of baricitinib and JAK inhibitor and steroid is strongly recommended for patients with severe COVID-19. Mortality and severe disease rate were reduced and no side effects are observed. This means a shift in the treatment of infectious diseases from antibacterial and antiviral therapy plus symptomatic treatment to antibacterial or antiviral therapy, steroid, immunosuppressive agent, biologic agent, JAK inhibitors, and symptomatic treatment. The WHO latest living guideline updated last month also recommended systemic corticosteroid, IL-6 blocker, and JAK inhibitor. Here, I would like to show you the COVID-19 therapy using cytokine signal inhibition, which is currently practiced at our hospital. This is 4 drugs regimen of dexamethasone, remdesivir, baricitinib, and heparin for patients requiring oxygen. Since April 20, 2020 to date, patient treatment with this regimen with moderate grade 2 or higher have had no transfer to NPPV or endotracheal intubation ventilation or death due to worsening COVID-19 pneumonia. This indicates that the clinical pathway using these 4 drugs very effective in treatment novel coronavirus infection. However, unfortunately, only 1 patient died of unknown cause other than coronavirus pneumonia on the 60 days after admission. Of course, IGRA in advance. During COVID-19 treatment, a doctor should be aware of infectious disease risks such as tuberculosis. IGRA measurements during COVID-19 treatment requires that COVID-19 treatment be initiated without waiting for IGRA results or other blood sampling in order to start the treatment quickly in severe case of COVID-19. Many COVID-19 patients have impaired immune function before treatment. In the detection of TB infection, please keep in mind the positivity of false negative result due to reduced immune function of the host. In my opinion, IGRA QST Plus is recommended to avoid false negative result. The same applies to IGRA measurement in the clinical course. My presentation almost comes to the end. At the end, may I ask these questions? Are you confirmation of latent tuberculosis infection before treatment? How the COVID-19 pandemic affected tuberculosis? Summary is biologics and JAK inhibitors have been developed for the treatment of autoimmune and anti-inflammatory disease. These agents were associated with decreased host immune function, and reactivation of infection is the most common adverse event. Among infectious diseases, tuberculosis continues to decline in Japan, although the spread of phenomenon has been apparently accelerated under the corona. Caution must be exercised. In Japan, it is mandatory to notify the authority when TB is diagnosed. According to drug package insert, various guidelines, TB and LTBI testing is mandatory for treatment with immunosuppressive drugs, biologics agents, or JAK inhibitor in the field of rheumatology, collagen disease, and dermatology. In RA with TB, concurrent treatment is possible, depending on the patient condition. Immunosuppressive drug is now administered to COVID-19 patients, in which case testing for TB is required. Thank you for your attention.